Hi everyone, we are moving on to chapter 21, which is the knee. So we're making our way down the lower extremity. So we're just going to go over some brief anatomy of the knee to get started with. It is designed for both mobility and stability. So we're going to go over the bony structures of the knee, the femoral condyles, the tibial plateaus, and the patella. The knee has a fairly lax joint capsule, which means it's loose, which means that will help with the mobility of the knee, or allowing for some mobility of the knee. So just to go over some of the bony structures, again, we have the femur that comes down in the femoral condyles. We have the lateral femoral condyle, which will then articulate with the lateral tibial plateau. We have the medial femoral condyle. There are menisci located on each side to sort of deepen that socket a little bit and improve the stability of the knee, because there's really not a lot, the tibial plateaus are not very deep for those condyles to sit in. So with the meniscus, that helps to sort of deepen that socket a little bit to add some more stability at the knee. Then we have the patella that rides through in between the femoral condyles and the femoral groove there. And then you have your fibula here on the lateral side. The four major ligaments of the knee are going to be your anterior and your posterior cruciate ligaments, and then your medial and your lateral collateral ligaments. And we'll go over each of them a little bit more in depth as we move on. So the major joint articulations that we're going to talk about are the Tibio-femoral Joint, which is the knee, the flexion and extension occurring there, and then the Patellofemoral Joint as well. So again, this is just another picture, all the same structures that we just talked about. The patella has been reflected in this picture, so you can see the underside of that and where it would fit into the patellofemoral groove there. You can also see your cruciate ligaments a little bit better in this picture. So just go over, again, the anatomy of the knee. The knee is a biaxial modified hinge joint. The condyles of the distal femur are asymmetrical. So the medial condyle, remember, is a little bit longer than the lateral condyle. This helps with the screw-home mechanism, which we'll talk about a little bit more, which is important for stability of the knee. This will also come into play as we get a little further on into the lecture as well and talk about osteoarthritis and why the medial condyle tends to wear down a little bit faster than the lateral condyle. So the two femoral condyles are going to interact or articulate with the tibial plateau, and the meniscus, again, is going to help to deepen and cushion that joint, and it improves joint congruency as well, so it helps the joints slide on each other a little bit better. This is just another picture of your medial and lateral meniscus. Your medial meniscus is also attached to the medial collateral ligament, so it's cut here, but there is attachment there. And you can see it also comes in and feeds a little bit into your ACL, the anterior cruciate ligament as well. So that is why we sometimes have what we call the unhappy triad. With a knee injury, can result in an ACL tear, a medial collateral ligament tear, as well as some medial meniscus involvement as well. So it's those three structures that make up the unhappy triad. The lateral meniscus over here on the lateral side does not have any attachment, or I'm sorry, the lateral collateral ligament over here does not have any attachment to the lateral meniscus. So I'm pretty sure you guys have gone over the screw-home mechanism before, but we're just going to touch on it a little bit here. In the open chain, that's where the tibia is going to move on the femur. And so when we perform terminal knee extension in the open chain, the tibia is going to rotate externally on the femur. That is going to lock the knee into extension. Then in order to flex, the knee has to unlock, so the tibia will rotate internally, and then the knee will go into flexion. In the closed chain, we are going to have the femur moving on the tibia. So for terminal extension in the closed chain, the femur is going to rotate internally on the tibia in order to get full extension and in order to fully lock the knee. I put a video in here that goes over some of these aspects with you. There is some fabulous music in there, so you can just ignore that. But I think it does do a pretty good job of showing the arthrokinematics in just the open and closed chain for the screw-home mechanism. It's not very long, so just take a few minutes and take a peek at that. So again, in the closed chain, the femur is going to rotate internally because of the discrepancy in the length of the femoral condyles. That will also help move the hip into extension. And then as the knee unlocks, the femur will rotate laterally, and the hip will begin to flex a little bit. With this interaction between the hip and the knee, if a person does not have full hip extension, so if their hip is stuck in a little bit of flexion, so think back to procedures, we talked about hip flexion contractures that could develop a person who sits for a really long time and their hip flexors get tight. If they can't fully extend their hip, then they're not going to be able to fully extend their knee either. And if they can't fully extend the knee, they can't lock the knee. This is going to lead to increased instability at the knee. So this can be a problem with gait a little bit further down the road. The Patellofemoral Joint, we're going to talk about that and some of the conditions that you'll see with the Patellofemoral Joint, but the patella is a sesamoid bone in the quadriceps tendon. It articulates in the intercondylar, trochlear, or patellar groove on the femur, and its job is to increase the torque of the femur and sort of lengthen the moment arm. So there you go. For patellar alignment, we want the patella to stay approximately in the center of the knee. It's stabilized on the lateral side by the IT band and the lateral retinaculum, and on the medial side, it's stabilized by the VMO. So the big thing to sort of take away here is our medial stabilization is muscular. Our lateral stabilization, the IT band, the lateral retinaculum, those are more inelastic type structures. And so there can sometimes be an imbalance between those structures, especially if VMO would get weak, right? So if VMO is weak, those lateral structures are going to tend to pull the patella more laterally. And so then that's going to cause the patella to come out of that groove or sort of shift more towards the lateral side of the knee. So we'll talk about that when we get into some of the patellofemoral dysfunctions a little bit later on here. There are multiple bursa throughout the knee. This picture shows a couple, but there are even more than this. They're the little blue dots on here. There's a prepatellar bursa. This is your suprapatellar bursa, the infrapatellar bursa. There's multiple bursas throughout the knee. And remember, bursa are just going to be fluid-filled sacs. They just help the tendons to glide a little bit more smoothly and give a little bit of cushion to the knee as well. Any one of these can become inflamed and become painful, and we'll talk about those again a little bit later on. You guys, I believe, have also talked about the Q angle at the knee before, but this is just the normal alignment of the patella. A typical Q angle is going to be about 10 to 15 degrees. Women sometimes have a little bit larger of an angle, and that's because women tend to have a little bit wider hips than men, which increases that angle. But the Q angle is calculated by two intersecting lines. So we're going to draw a line from the AS-IS to the midpoint of the patella, and then another line from the midpoint of the patella to the tibial tuberosity or the tibial tubercle. And so the angle between those two lines is what gives us our Q angle. We can see increases in Q angle, and an increased Q angle is going to present like this middle picture here. So again, increased Q angle, normal is about 15, so more than that, more than 20 degrees or even above and beyond that, can come from all of these different reasons over here. So this is basically showing genu valgum, right? So if a person has a genu valgum deformity, that is typically going to increase your Q angle. We know that that can sometimes be seen with coxavera, right? So if we change the angle at the hip there, that's going to result in this angle at the knee as well. If the patella rides high, patella alta, that will increase the Q angle. If the person has pronated feet, right? So with all of this, with coxavera, genu valgum, we tend to also see increased pronation at the feet. So with that will come an increased Q angle as well. We talked about how women have wider pelvises. A wider pelvis is going to increase that Q angle at the knee. If there is increased femoral anteversion or external tibial torsion, either one of those will also increase the Q angle as well by internally rotating the femur or externally rotating the tibia. So patellofemoral pain can be associated with muscle and fascial tightness, like if the IT band or the lateral retinaculum get tight, or as I mentioned before, if the VMO gets weakened, which can happen following any type of knee injury or surgery, then patellar tracking can become off as well, because the lateral structures are going to tend to pull the patella more laterally. Just a quick review of the ligaments again, because the ligaments are really important to the knee. The ligaments are what's really providing the knee with most of its stability, and the muscles as well. But as far, there's just not a lot of bony congruency here. I mean, really the femur is almost just resting on top of the tibia. The meniscus helps to deepen that socket a little bit, but again, we're really relying on those ligaments to help provide stability for the knee. So again, remember we have the MCL and LCL, your collateral ligaments, and then your ACL and your PCL, your cruciate ligaments. We will test all 4 of those ligaments. I will either upload videos for you or make videos for you to show you all of the special tests for the knee. But it's typically pretty quick and easy to sort of just screen out all 4 of those ligaments and make sure that they're stable and doing their jobs. We often test in both full extension, although remember full extension is kind of locking the knee, so it might appear that the knee is more stable if we test in full extension. So sometimes we also test in resting position, which is about 25 degrees of knee flexion. This is also considered the open pack position of the knee. It's a position of comfort, right? Open pack versus closed pack position. Open pack means that there's some space between the bones. Closed pack would be full extension of the knee, where the bones are as close as they possibly can to one another. So this is why people will tend to flex their knee a little bit following injury and following surgery, because it's a little bit more comfortable position. The capsular pattern for the knee is going to be flexion is usually limited first, and more so than extension. Quick review of the muscles of the knee. This first picture is a posterior view of the knee. So we have the hamstring muscles, the semimembranosus and semitendinosus here on the medial side, and then biceps femoris on the lateral side. We see the gastroc here, the 2 heads of the gastroc, and then plantaris is tucked away sort of underneath there. They are showing some of the fibers of gracilis here on the side, the medial side as well. That is one of the muscles that's going to make up the pes anserine. On the anterior aspect of the knee, we've got the quads up here. So we have vastus lateralis, rectus femoris, vastus medialis here over on the medial side. Intermedius would be underneath all of these. We have the peroneal muscles here on the side, tibia anterior right in front, and then we're getting a little peek of gastroc there on the back side as well. So knee extension is primarily controlled by the quads, especially in the open chain. In the closed chain, we are getting some stability added by the hamstring and the soleus. They help to pull the tibia a little bit posteriorly, but even with that in the closed chain, the quadriceps are going to help to control full knee extension. Peak torque of the quads is going to occur at 70 to 50 degrees of extension, and then decreases as the knee gets closer and closer to full extension. And that's all due to the shortening of the moment arm. Knee flexion, primary knee flexors are going to be the hamstrings, as well as gastroc can help with that a little bit because it does cross behind the knee. Both the hamstrings and the gastroc are going to help support the posterior capsule of the knee and prevent against some hyperextension. But again, remember, it's the quads that are really controlling hyperextension and not allowing the knee to snap back into hyperextension. Popliteus also supports the posterior capsule and assists with unlocking the knee, so that's going to help to sort of initiate flexion of the knee. And then we have the pes anserine muscle group, which again, the pes anserine is made up of sartorius, gracilis, and semitendinosus, which is going to provide some medial stability to the knee and affect rotation in the closed chain. So we need at least 60 degrees of knee flexion for normal gait for ambulation. We want 0 degrees at initial contact. And remember, we want 0 degrees at the knee so that the knee can be locked and be stable as we start to accept weight onto that leg. And then we need about 60 degrees during swing in order to clear the toes so they don't drag on the ground. The quads, again, are going to help to handle loading response and extend the knee towards mid-stance, again, controlling that knee into extension in the closed chain. And we do want normal 0 degrees, full extension at the knee. And in some women especially, we tend to see some genu recurvatum or hyperextension of the knee, even up to 15 degrees. I would say that's a decent amount. We would hope to maybe see a little bit less than that. But here's some pictures of some serious genu recurvatum. That is not normal, we need to do some serious quad strengthening with these individuals. That is also, you can see the amount of hyperextension in that leg there. So again, lots and lots of quad strengthening to try to help improve the stability of those knees. Hamstrings are going to eccentrically control forward swing, right? Not letting that leg just snap out into full extension. And then it also helps, the hamstrings also help to support the posterior capsule in stance. Gastroc, again, supporting the posterior capsule in stance and full extension, and loss of function of the gastroc or weakness of the gastroc can result in some hyperextension as well as decreased push-off prior to swing. Again, if the person is not able to fully extend their hip, if their hip is stuck in flexion due to a contracture, due to tightness of the muscle or adhesions, they're going to have issues through gait. So you can see in this picture, flexion at the hip is typically going to result in some flexion of the knee as well. So if they can't fully extend the hip, they are most likely not going to be able to fully extend the knee as well, which is going to lead to some instability during gait. This can also lead to pain in the knee. You can see that there are going to be some different forces placed on the knee when the knee is kept in a little bit of flexion. It's also going to put some more force on the patella as well. So anterior knee pain can be resulting from overuse of the hamstrings, which causes then posterior translation of the tibia on the femur, which can produce increased compression of the anterior joint capsule. We need the quads to help compensate for that, to create more anterior space. We can also see anterior knee pain if the patella is tracking more laterally. So like I said, weakness of the VMO can cause the patella to track more laterally because the IT band and the lateral retinaculum, those more fibrous, tight structures, are going to pull the patella more laterally and cause it to sort of jam into the lateral femoral condyle. Pes planus, or flat-footedness, or pronated feet, can cause or will cause medial rotation of the tibia, which can then also cause the patella to basically essentially track more laterally as well. So again, you can see too, this is depicting the lateral side of the patella. That side's going to stay relatively tight. If the VMO gets weak, then the lateral structures are going to sort of win that tug of war and pull the patella more laterally, and then there'll be much more compression between the patella and the lateral femoral condyle. Okay, so let's get into some conditions of the knee. So joint hypomobility, and we're going to start with non-operative management. Typically when we start talking about hypomobility of any of the joints, we're going to talk about osteoarthritis. Rheumatoid arthritis can also occur at the knee, and we'll talk about stiffness due to post-immobilization situations as well. So osteoarthritis. This is a diagram just sort of depicting the wearing away of the cartilage at the end of the femoral condyle, so you can imagine that's going to be rather painful. I want you to take note in this picture too. Again, the medial femoral condyle does tend to wear away faster than the lateral femoral condyle. It's longer, so it's going to be in more contact with the tibial plateau here. So the medial side of the knee does tend to wear away faster than the lateral side. If you look at this x-ray, here is the right versus the left knee. Left knee looks okay, pretty symmetrical, even joint space there on the left side. When you get over here on the right side, you can see it's narrowed on both sides, but definitely the medial side is more narrowed than the lateral side. You can see this bright white line down here. Again, increased bone deposition, Wolff's Law, because of the compression of those two surfaces there. And you can actually even see some osteophytes starting to develop around there as well. So all those characteristic signs of osteoarthritis are present on that x-ray. So osteoarthritis is also known as degenerative joint disease. With osteoarthritis, the most common deformity that we see is genu verum. So we actually see bow-leggedness start to develop, even unilaterally. OA is typically unilateral. I have a picture on the next slide, I think, that will show you why that happens, but it is typically genu verum that develops with osteoarthritis because of increased wear on the medial aspect of the knee. This is one of the most common diseases that affects weight-bearing joints. Hips and knees are going to be the most common joints in the human body that exhibit the signs of osteoarthritis. Again, articular cartilage is going to be worn away more medially versus laterally. This can result in knee instability, a sense that the knee is sort of buckling or giving out on the person, which will then eventually start to impair ADLs. So even things like walking, gardening, athletic activities, household activities, anything ADL related is going to be affected by osteoarthritis and pain because it hurts to weight bear. So anything where you're up and moving is going to be affected. Risk factors for osteoarthritis are the same as we've always talked about. So obesity, previous joint trauma to that knee, any developmental deformities, weakness in the quads, and abnormal tibial rotation. So any abnormal alignment can cause increased wear and tear on the knees. So this picture sort of shows, again, why we see sort of that bow-leggedness start to develop. So here is the x-ray of the knee progressively showing more and more signs of arthritis. And so you see that that medial compartment sort of starts to collapse a little bit, and it gaps a little bit here on the lateral side. And so that is what makes us end up with genu verum on osteoarthritic knees. So again, previous trauma to the knee can accelerate the arthritic process. And then trauma is going to lead to things like joint swelling, pain, limited motion, muscle guarding, which we'll see with osteoarthritis as well. Rheumatoid arthritis can also affect the knee. Again, it's more often seen in the hands and the feet. It may progress to the knee. Oftentimes what we see is someone who has rheumatoid arthritis, and then it can progress to osteoarthritis of the knee. Rheumatoid arthritis does tend to be more bilateral. So if you're seeing bilateral knee symptoms, that might be a sign of RA. Another big distinguishing factor between RA and OA is that with RA, we tend to see genu valgum as the primary deformity. So it's the opposite of osteoarthritis. Through both OA or RA, we're going to see hypomobility of the joint. If there's trauma in the joint, it may swell immediately or it may swell a little bit later. If it swells immediately, that is usually indicative of bleeding in the joint, and then we'll see resultant muscle guarding, weakness, limited motion. If the swelling takes a little bit longer, like 4 hours or more, that is a more indicative of serous effusion, which is usually more indicative of a ligament tear or a meniscus tear. Again, whenever there's swelling present in the joint, the person is most likely going to assume a position of about 25 degrees of knee flexion, because that is an open pack position that's going to give more room within the joint for that swelling to take place. So again, that's the point where there's the greatest capsular distensibility. And this can lead to then extension lag with active versus passive range of motion. So I'm going to talk about extensor lag here for just a second. I found this video. And I think it's like 2 minutes long or something like that, but really you can watch the first couple seconds of this video and you get a pretty good picture of what extensor lag looks like. So this is when we see it's due to weakness of the quads. So we ask the person to do like a quad set and they have difficulty performing the quad set. We typically look for extensor lag with a straight leg raise. So with a straight leg raise, we often give the patient the cue, tighten up your quads, do a quad set, keep the leg nice and straight, and then lift the leg off the table into hip flexion. So what this video shows is someone who's trying to keep their leg straight, but as they start to lift it off the table, you start to see a little bit of bend in the knee. The knee starts to flex a little bit, and it's because the quads are too weak to maintain full extension at the knee. You can also test this in the person. You could have them do basically like a quad manual muscle test. So they would short sit on the end of the table. You would ask them to fully extend their knee. They would probably be lacking those last couple of degrees of extension. So what you would do is then you could passively lift them the rest of the way up into extension. If you can passively move them into extension, it's not because their knee's stuck in flexion. It's not like they have a knee flexion contracture. It's because they have weakness of the quads. So one thing we can do is we can actually measure this with a goniometer, how much extension lag is present, and then theoretically, hopefully as that patient gets stronger and stronger, we start to see less and less extensor lag. So watch this little video. You can watch it the whole way through. It does show the patient doing several straight leg raises. But again, you get a pretty good picture of what it looks like within the first couple of seconds. This is, again, just another picture showing some extensor lag, quad lag. And again, it's all due to weakness of the quad. So this is a person following a total knee replacement. This is fairly common following total knees and ACL reconstructions, again, because of the weakness of the quad. So post-immobilization joint restrictions can develop, contractures and adhesions. Most often what we see is knee flexion contractures develop because flexion is that comfortable position. So people tend to stay in flexion. So again, think back to procedures, try to avoid putting pillows underneath the legs and encouraging that knee flexion. Try to encourage as much knee extension as we can initially. Adhesions may also restrict gliding of the patella. If the patella does not glide the way that it should, that's going to restrict knee range of motion, especially knee flexion. So if the patella is not moving the way that it should, you're not going to be able to flex the knee as much as you want to be able to. So in the maximum protection phase, when we're dealing with we're still talking hypomobility, so OA, RA, or post-immobilization hypomobility. We want to try to control pain. We want to maintain soft tissue and joint mobility, so patellar mobility. We're going to do passive, active assisted, active range of motion, all within the patient's pain tolerance. We can do grade 1 or 2 traction or glides. This is usually referring to the patella. So we're just talking about mobbing the patella or gliding the patella. Multiple angle muscle setting or isometric exercises. So we can do quad sets, hamstring sets, possibly even some glute sets here. Submax closed chain muscle setting. So trying to do some in a closed chain position as well. We typically try to avoid stretching at this time because of the distensibility of the joint capsule with RA and the changes in the joint structure and function. We want to try to limit that to some degree, a lot too, because we can sort of overstretch at this phase. So we can do quad sets again with leg raising. So again, making sure that they have the strength to perform this activity. Protect the joint, so we might try to do more open chain activities versus closed chain activities. An assistive device may be necessary. Maybe if we can offload that joint a little bit, we can make ambulation more comfortable for the patient. So fitting them for a cane might be of benefit to them. Again, some patient education, make sure that they're not developing contractures. Again, they're going to want to keep that knee in a little bit of flexion. So encourage them to stretch it out and make sure they're still able to maintain full extension at the knee. And then again, make some functional adaptations to their environment because this is not something that's going to go away on its own. So things like elevated toilet seats, maybe even a bedside commode, reduce the depth of sitting in chairs, sofas, whatever's, have them sit on a pillow or something to keep them up a little higher to make sit to stand a little bit easier, and try to reduce the amount of stair climbing if at all possible because of the amount of flexion that's in the knee with stair climbing. That does increase the compressive forces at the knee, and that can become painful and increase the wear and tear on the knee as well. So in the controlled motion and return to function phases, so as the person feels better, right? So in the acute flare-up phase, they're having a really painful time with the knee. We want to kind of take it easy on them. When they're feeling okay, when the pain is not at its worst, we can work more on range of motion and stretching at this point. We can increase joint play, continue to increase range of motion. So we might do some joint mobs and mobilizations with movement. We can work on functional activities, and we can do some more strengthening here and progress that. Again, with range of motion, a precaution here is to make sure that the patient has sufficient strength to control the motion that's available. And so that's what if we continue to stretch and stretch that knee and we get them more and more range of motion, but they don't have the strength to control it, again, this can lead to some instability and potential fall risk. So again, a mobile joint with inadequate muscle control is going to lead to poor stability and will make weight bearing a little bit more difficult and painful. Again, as far as stretching goes, we may exacerbate their joint symptoms. So again, we want to sort of take that slowly. Do some range of motion, some active range of motion, maintain what they have, but just be careful with really, really stretching when we're in this phase. Okay, so some surgical procedures for OA and RA. I lumped all of these together on this slide. These all sort of fall under the category of trying to actually repair the cartilage. So basically these procedures are trying to either stimulate more cartilage growth or add more cartilage to the knee, basically to delay a joint replacement. So we've talked about most of these procedures before. These were in those chapters where we talked about surgical procedures. So microfracture is where they go in and they do tiny little microfractures to the bone, to the distal tibial, the tibial plateaus or the distal femoral condyles, in order to try to stimulate more articular cartilage growth. They can do an osteochondral autograft transplantation or a mosaicplasty, which is again where they're taking chondrocytes from another non-weight-bearing site of the body and trying to stimulate more cartilage growth and then reinserting them into the knee. They can do chondrocyte implantations or allograft transplantation, so getting cadaver tissue. All of these have a relatively lengthy rehab process in order to try to allow that cartilage to grow. So these are not done very commonly. I doubt you'll see too many patients who have any of these surgical procedures done. Much, much more commonly, what you're going to see is the total knee arthroplasty. So this is going to be indicated when the patient has tried non-conservative treatment, they've done therapy, they've done pain medicines and things like that, but they're still having severe pain with weight bearing that is impacting their quality of life. So usually, again, extensive destruction of their cartilage is going to be visible on x-ray. If they have gross instability of the knee, a lot of deformity of the knee, like the genu valgum or genu varum, and again, failure of those non-operative type treatments. So this is a diagram of what the components of a total knee replacement are going to look like. So think back, remember you guys watched the hip. So this is what they're going to do with the knee. They put lots of plates to sort of guide the saw here to take off the ends of the bone. This is going to be the femoral prosthetic component. They will take off the top of the tibia, remount the center there so that they can put the tibial component in, and then they may or may not resurface the patella. If there are arthritic changes, they may put a little patellar button, they call it, on the back to resurface that so that it will continue to glide smoothly. This can be cemented or uncemented. Again, typically the older the patient, the more likely they are going to be cemented. The younger the patient, they may go the uncemented route. If they are cemented, they are typically weight bearing as tolerated immediately, and we will get them up and moving right away. So just like the total hip video, here is an animation. It's not a real surgery, so if you don't like blood and guts, you're good. An animation of what goes on with a total knee replacement surgery. So take a couple minutes and watch that so that you have a pretty good understanding of what's going on there. So again, the posterior patella may or may not be resurfaced depending on how much it's worn away. So the doctor will usually actually take it out and they'll feel it with their, or flip it over and they'll feel it with their thumb. And if it's nice and smooth, they'll leave it alone. If it's kind of roughed up, then they will usually go ahead and remove that and put the patellar button on the back. The MCL and LCL ligaments are typically left alone during the surgery. The ACL and the PCL are typically removed with a total joint replacement. There is a fully constrained option, meaning that there's going to be like a link between the two components, or like a hinge in there between the two components, but that's going to be for your pretty low level patient who needs a lot of stability and is not going to be up and on that leg a lot. Again, early on, try to avoid using a pillow under the knee to avoid that knee flexion contracture from developing. Watch for wound care techniques, make sure that the wound is healing properly. They are going to have an open incision on the anterior aspect of the knee. It's typically closed with staples, and those are usually removed about 7 to 10 days after surgery. So do watch that too. We don't push the patient into a lot of knee flexion in those first couple of days post-op, because you can imagine if you had staples on the front of your knee and you were trying to bend it, they're just going to dig in a little bit more, and that's not going to be very comfortable. So usually once those come out, the patients feel a bit better and you can start working range of motion a little bit more aggressively at that point. So the maximum protection phase following a total knee replacement is considered weeks 1 through 4. So we're going to control pain and swelling. We're going to teach the patient some bedside activities such as ankle pumps. We can start with active assisted range of motion. I really like using like the green stretch out straps, or even just a sheet or a belt or a dog leash to do some active assisted heel slides. We can progress to more active range of motion. We're going to do muscle setting exercises. So again, this is going to be our quad sets, our hamstring sets, maybe even some glute sets as well. We can do some patellar mobs or patellar glides. Again, we'll hold off on those until after the staples are removed, and you can teach the patient to do them themselves as well. We're going to definitely work on gait training. So get the person up and walking. Again, this typically starts either post-op day 0, the day of surgery, or post-op day 1, the day after. By the end of this, by the end of 4 weeks, if the person was not using an assistive device prior to surgery, we're going to hope to get them back to not using an assistive device by about a month out. We will work on some flexibility, so do some stretching exercises, focusing on the hamstrings, the calf, the IT band. We can also do some trunk and pelvic stabilization type exercises, so doing some core stability type stuff. During the first 4 weeks, our goals for range of motion at the knee is 0 to 90 degrees. So by the end of this 4 weeks, we want to have full extension back at the knee, and we'd like to see at least 90 degrees of knee flexion. The moderate protection phase is moving into weeks 4 through 8. So we're going to start to shift from range of motion. We just really focus a lot on gait, mobility, range of motion in that first phase. The second phase, the moderate protection phase, we're going to add a little bit more strengthening in as well. So the person should be full weight bearing by this point. They should have unrestricted ADL function, so they should be getting around pretty well. We can continue to do some patellar mobs or glides if they're needed. Hopefully it's moving pretty well by this point. Continue with lower extremity stretches to make sure we're maintaining that mobility, not letting the knee flexion contracture start to develop. We'll begin some closed chain strengthening or progress it a little bit more at this point. We can do some limited range progressive resistive exercises. Because again, they might not quite have full range of motion back at their knee yet, but just continue to strengthen whatever range they do have. We're going to do some proprioceptive stabilization and balance exercises at this point. And then we also want to try to work on some cardiopulmonary endurance type activities, so some aerobic exercises, and still try to protect that knee. So things like aquatics, cycling, those would be best where they're non-weight bearing or not weight bearing as much, and walking would be okay as well. Our goal range of motion at this phase, or at the end of this phase, is to get up to about 110 to maybe even 120 degrees of knee flexion, still wanting to maintain that 0 degrees of extension. And then the final phase, your minimum protection or your return to function phase, is from 8 weeks and beyond. So basically, we're just going to continue to progress all the exercises that we were previously doing, progress the balance activities, progress functional activities. If there's any deficits noted anywhere, address those specifically. Continue to improve cardiopulmonary endurance, and again, in ways that we can continue to protect that knee. So if the person has access to aquatics, awesome. If not, walking, elliptical even, or cycling would be good for them. And we do expect them to be able to ambulate community distances by this point, so they shouldn't be limited in their ambulation any longer. Okay, so now we're going to talk about some patellofemoral dysfunctions. Patellofemoral instability, here we're talking about subluxation or dislocations of the patella. Typically, we're going to manage that non-surgically. And then we'll also get into patellofemoral pain or patellofemoral syndrome with or without malalignment or biomechanical dysfunction. VMO, strengthening quad sets, straight leg raise, isometric, short arc quads, anything to really sort of strengthen the quads, which will also strengthen VMO. We want to not irritate the synovial lining of the suprapatellar palate or the bursa, so we want to avoid short arc quads, again, because of the angle that it puts the knee in and the compressive forces of the patella against the femoral condyles there. Again, some other factors that can lead to patellofemoral symptoms, infrapatellar fat pad irritation, patellar tendonitis, quadricep tendonitis, medial and lateral retinaculum irritation. Again, walking and squatting are typically going to increase these symptoms. There can be factors that happen at the foot. There can also be factors that happen at the hip. Things like overpronation of the feet, things at the hip like weakness of glute med, which can cause the inside of, or cause increased forces on the knee. Genu coxavera at the hip, which increases Q angle. So all those things that we've talked about previously can also lead to some patellofemoral symptoms as well. So again, impairments that we're going to see with patellofemoral dysfunction, weakness, inhibition, or poor recruitment of the VMO. So looking for, again, complaints of anterior knee pain and then associated VMO weakness, an overstretched medial retinaculum, restricted or tight lateral retinaculum or IT band, decreased medial gliding, so it appears that the patella tracks more laterally, and you can look at that too when have the patient sit long sitting on the table and do a quad set, and the patella should move straight up the center. If it appears that when they quad set the patella is moving more laterally and it's painful, it's typically a sign of poor patellar tracking. Pronated feet will increase the incidence of this. Tight gastroc, soleus, hamstrings, rectus femoris, again, any muscle imbalances in the leg, irritated patellar tendon or subpatellar fat pads, and patellar crepitus swelling or locking at the knee. Again, the patient's going to report typically anterior knee pain, fairly local, and poor knee control. Again, we see that on stairs a lot. They will report pain with walking, jumping, or running, which then interferes with ADLs and recreational activities. Pain and stiffness with prolonged flexed knee posture, so like sitting for long periods of time, whenever they get up to move, it's painful and stiff. Again, if the non-operative treatments don't seem to work, they may do a lateral retinaculum release to realign the knee joint and improve patellar tracking. This is again where we can also get in with patellar taping. The idea is that we will tape the patella in a better position, which will allow the person to do exercises without as much pain, will strengthen the leg, and then again, once we get VMO strengthened again, it can help to stabilize the patella. So again, those are the more conservative approaches, and if those don't work, then the person may elect to have a surgery. Now we're going to move on to ligamentous injuries, and the most common ligamentous injury at the knee is going to be an ACL tear. So we're going to spend most of our time talking about that, although we will mention all the other ligaments as well. So the ACL is the most commonly injured ligament of the knee. Oftentimes it's more than just the ACL. According to some recent literature, 78% of all ACL injuries occur due to external rotation of the tibia on a planted foot, but it can also result from a lateral blow resulting in a valgus force to the knee. So usually it's a combination of hyperextension and a valgus stress to the knee. And again, when I said it's not usually, it's more than one ligament, we do tend to see that unhappy triad. So that's involvement of the ACL, the MCL, and the medial meniscus. So this video is going to show you the mechanism of injury for an ACL. Again, it's typically with the foot planted and then an external rotation of the tibia. So it's planting the foot and then rotation, which is going to tear the ACL. It can also be from an external force, but again, we've seen that most injuries are due from that external rotation of the tibia. So that would be a non-contact injury. So you can just, it's a fairly short, it's an animated video that shows you how most ACL injuries occur. We can also have injuries to the PCL. This is usually happens with a forceful blow to the anterior tibia with the knee inflection. So usually where we see these is things like someone's in a car accident and the dashboard comes back and hits their knee and pushes the tibia posteriorly, and then the PCL is torn. Football tackles, when they come in and you get hit, that anterior blow to the tibia, that's when the PCL is often torn. The MCL can be torn in isolation, but it can also be involved with an ACL injury because it's almost the same mechanism of injury. So that force that causes the ACL to tear can also put a strain on the MCL as well. Many times the MCL will not completely tear. This will be graded, a grade 1, 2, or 3 sprain like we talked about again earlier. The LCL, we rarely see injuries to that, especially not in isolation. So common impairments following an ACL injury is that, again, the joint is not going to typically swell right away. It usually takes a couple hours. Again, if it's immediate swelling, it's usually due to torn blood vessels. There will be pain with stress testing if the ACL is intact. If it is completely torn, it's typically not as painful, but you can tell that pretty easily upon stress testing. So again, they'll be unstable when they are tested. And I will show you guys, again, some special tests for that. The most common special tests for ACL stability are called the anterior drawer test or Lachman's test. They will have pain with weight bearing initially and instability with ambulation as they're able to ambulate more and more. Just keep in mind that ligamentous injuries do not always require surgical interventions. You can tear your ACL and don't necessarily have to have it repaired. Now, if you plan to go back to playing sports and being really athletic, you want to have it repaired. But if you're not, you don't necessarily have to have it repaired. You can strengthen the surrounding musculature and you can get around just fine. My brother-in-law walked around for several years without an ACL. If there are loose bodies present though, so if the ligament tears and then pieces of it kind of break off, they usually will do a surgery to go in and remove those and repair the damage at that time. So ACL reconstruction, they can do an allograft transplantation using cadaver tissue. Most commonly what they do is an autograft, so they use the person's own tissue. And there's two major approaches. There is the patellofemoral graft or the hamstring graft. There are pros and cons of each one of those listed on page 810 and 811 in your book, so you can take a look at those, and there are advantages to each. We don't get to choose. The physician's going to choose which method they typically use for that. You do want to be aware of which graft your patient has, because then following surgery, rehab looks a little bit different. If they did a patellar graft, we have to not do some quad strengthening for a period of time. If they've had a hamstring graft, we have to lay off the hamstrings for a little bit of time in order to let where the graft sites heal. So I did include an animation here, again, of an ACL reconstruction surgery. So again, you have an idea of what that looks like. I do think it's really important for you guys to sort of understand what's happening during these surgical procedures so that when you're working with the patients right afterwards, you can sort of talk to them about what has happened and sort of understand why they're presenting the way that they are. So the goals of doing ACL reconstructions are we want to restore joint stability is the biggest thing, to give the person pain-free, stable weight bearing, increase their strength and endurance, and then return to their pre-operative activities. So be able to get them back to sports and recreational activities. So I've included some basics here for ACL rehab. Most patients are going to come with a protocol from their physician, so make sure that you're following the specifics that are outlined for you there. But in general, maximum protection is going to be about 1 to 4 weeks. We expect full extension and 90 to 100 degrees of knee flexion by the end of this phase. Initially, we're going to start with things like price gait training with crutches, passive range of motion progressing to active assisted range of motion, so heel slides to work on knee flexion and extension. We can do some patellar mobs and glides just to make sure that the patella is moving the way that it should and that's not hindering knee motion in any way. We'll start with isometric exercise, so quad sets, hamstring sets, adductor setting, so that's usually like squeezing a ball between their knees. We can start with assisted straight leg raise. It's going to be very difficult for them to do full straight leg raises right away. But then once they get the hang of that, we typically just start with flexion and then we can progress to all 4 planes. Start with some ankle pumps, open chain knee extension. We'll do some progressive resistive exercises for the hamstrings. We could also do some trunk and pelvis stabilization, which will sort of take the focus off their knee for a period of time. And we can begin the stationary bike here too. So just start usually with some rocking back and forth until the person can make a full revolution. Moderate protection phase is going to last from about 4 to 10 weeks. We'll add multiple angle isometrics and then progress to some more closed chain progressive resistive exercises. Continue to do a lower extremity stretching program, so making sure things like the hamstrings, the calf, the IT band all remain nice and flexible. Begin to do some endurance training like the bike, the pull, the elliptical, so again protecting that knee to some degree. We want to focus a lot on proprioceptive training during this point. So begin with some single leg stance activities. We can work on the balance board, the bozu, and progress all of those things as we're able. Eventually, closer to the end of the phase, we're going to get to things like high speed stepping, balance on unstable surfaces, balance beam, stabilization exercises, band walking. We're going to do lots and lots of glute med strengthening, especially with our female athletes who've had ACL reconstructions. And then again, by the end of this phase, we'll initiate a walk or jogging program depending on where the person is. And then as we progress into the maximum protection phase, which can go from 11 weeks to 6 months out, make sure that we're maintaining lower extremity mobility through stretching. We're going to continue to advance and progress the progressive resistive exercises, closed chain exercises, and we're going to add plyometrics at this point. So bouncing, jump rope, box jumps, start with double leg, and then you can eventually progress to single leg. Again, continue to progress proprioceptive and balance training, challenge your patient, add some agility drills, and then start to simulate sport-specific training. Again, by the end of this phase, as we get closer into the 6 months, even into 9 months, we can start to transition into full speed jogging, sprints, running, and cutting. And then again, all in to try to get the person back to sports. Typical return to sports following an ACL reconstruction is a minimum 9 months, usually closer to about a year. Again, like I said, not everyone is going to have their ACL reconstructed. So if they don't, we want to avoid resisted open chain terminal knee extension and closed chain knee extension between 60 and 90 degrees of flexion. Again, this is because of the angle of the femur on the tibia at this point, which is going to put a lot of stresses or sort of force the knee into that anterior tibial translation, which is what the ACL normally protects against. And if it's not there, it's going to put some awkward forces on the knee. So we do want to be careful if we're working with a patient who does not have an ACL. All right, moving into meniscal tears. Again, medial meniscus is most often implicated. The lateral one, we can have tears in the lateral meniscus, but they are not quite as common. And again, also because the ACL is attached to the medial meniscus, we often see those injured together. Common impairments that we see with meniscal tears are going to be like a locking of the knee, a clicking sensation, a feeling that the knee is giving out on the patient. They will have pain, edema often, and weakness of the knee. There are non-operative managements. We can do manipulations to try to unlock the knee, try to maneuver or reduce the meniscus, improve strength and endurance, and try to either put off surgery or maybe not even need surgery in the long run. Surgical management is when they go in. This is usually done arthroscopically, and they'll go in and they can try to repair meniscus. The meniscus, depending on where it is not very vascularized. Only the outermost portion of the meniscus has a pretty good blood supply as you get further and further in there, which is where you're going to have more compression and more likely to tear. Less and less blood supply, so less likely to heal in here. So they can try to repair it. So they can stitch it or try to repair the torn piece of meniscus. Or what they will often do is a meniscectomy, where they will go in and they will just remove the torn part. Pros and cons to that. The biggest con, obviously, is that you're removing part of that meniscus, which is part of the cushion for the knee. So the patient is going to more likely have some breakdown of the knee there. Typically, most patients that I have seen post-meniscectomy rehab relatively quickly. We do want to avoid things initially like full squatting and lunges because of the forces that those put on the knee and the compressive forces there. We also want to watch things like twisting, turning, and pivoting at the knee if they repaired the meniscus. If they've removed the meniscus, you can usually get to those activities a bit sooner. Again, typically what they're going to do is a partial meniscectomy. They're only going to take away the part that was damaged. They want to leave as much as they possibly can because the meniscus is the cushion for the knee. So patients who have partial meniscectomies, again, typically rehab pretty quickly. They feel pretty good pretty soon. So we just want to make sure that they're not pushing themselves too quickly. If they progress too quickly, they could possibly cause more damage to the cartilage of the knee. This is a very conservative rehab approach, and this is, I'm guessing from your book, a removal of a huge chunk of the meniscus. So maximum protection phase would be 4 to 6 weeks, focusing on range of motion, patellar mobility, isometric exercises. The person may be braced. They can do mini squats without the brace, and flexion at least 45 degrees. Moderate protection, get full range of motion back. You can add biking with resistance, T-band strengthening, progress balance exercises, progress to step ups and step downs, do the treadmill, elliptical, and then minimum protection, return to function, and progress all previous exercises. But that's not till 12 to 16 weeks. Like I said, most patients with partial meniscectomies, one, may not even need therapy afterwards, and if they do, they usually progress pretty quickly. So this is a super, super conservative approach that was talked about in your book. All right, guys, we made it through that one. Thanks for bearing with me, and next we will move on to the ankle and foot.